Let me now introduce to you Dr. June. She will deliver her talk on palliative care, special emphasis on psychosocial and spiritual care. I just want to say a few words about her. Some time ago, I happened to meet her first time in a conference, in a palliative care conference. And I went there. It was a very cold environment. And I was literally shivering because I didn't take my suit with me. And June was there, came up and said, "Are you feeling uncomfortable?" I said, "Yes, I'm feeling so cold." She quickly went and grabbed somebody's, the nurse's shawl, and then she passed it to me. And I was very touched by that simple act of, kindness, caring, and a spirit of, humbleness, a very friendly and caring person. So I think I'm very happy that she is heading this program, the palliative care, where a person of that nature, so sympathetic and so kind to patients. She's a palliative care physician practicing in Queen Elizabeth Hospital in Sabah. Over to you, Dr. June.
Thank you so much, Dr. Megan. Good evening, ladies and gentlemen, and everyone. Thank you so much again for having me back. I apologize that I have to turn off my camera so that the internet connection is a bit better to transmit my voice. And hopefully, with God's grace, we have no interruption during the talk. Let me share my slides.
Yeah.
So it is my pleasure tonight again to actually talk about this topic that I feel very dearly in my heart. First, I'd like to make a disclaimer that my views and opinions and the content of these presentations are solely my own and it doesn't represent my hospital. And I hope to cover a few things in the next half an hour, which includes how we assess the patient's social aspects, psychological aspects, and spiritual aspects in providing a holistic care to our patient. So this is just a refresher of what we covered last time when I had the chance to meet all of you. Palliative care actually pride itself to provide a holistic care. This is the WHO definition of what palliative care is. So it's an approach that actually helps to improve the quality of life of not just patients, but also the families who are facing life-threatening illnesses. And we hope that we can prevent and relieve suffering, not just from the physical aspects, but also the psychosocial and spiritual aspects. And this model actually is adopted from Dame Cicely Saunders' idea of total pain, where she believes and she advocates that the pain experience or the disease experience is not just one of the biomedical experience, but it's actually one of a psychosocial, and spiritual experience of the patients. And therefore, if we want to care for the patient well, then the attention should not just be on physical aspects, but also the non-physical aspects of the patient. And the whole care should be patient-centered and tailored to the patient's who the patient is and what his or her values are. First, I would like to go into social assessment and care. So in social assessment, we actually focus on two things. Number one, how good is the social support or the network for the patients? So that we know that whether he or she will be well looked after in the home in the community setting. And the second question we not often ask is how is the caregiver himself or herself coping in providing or in her as a caregiver. So this is a genogram. I believe half of the audience are actually from medical background, if not more. So I think some of my contents are probably more tailored towards healthcare professionals, and I apologize if some of the terminology may be a bit more alien to those who are not from medical background. So genogram basically is a diagram that we draw for our patients to try to depict or get a better ideas of who are there in the family or in the family of the patients. And often we try to have 3 generations. So in this diagram, if it's drawn well, it should give us a very clear idea on how many dependents the patient have, meaning how many people are depending on the patient for care or for financial support. And the diagram should also provide an idea to us on how much of supports are available for the patient if the patient become weaker or become more, say, bedbound and requiring full-time caregiving. And often, if we have the genogram, then if there are issues that we identify or we pick up along the process of looking after patients, then we will know who we should be inviting into the family discussion so that we can optimize the support for the patient. So apart from genogram, we also try to identify the caregiver's coping mechanisms. And we do this by asking the caregiver to complete it's like a questionnaire to help us understand what coping styles the caregiver often use. And this is a validated tool in the medical field on identifying coping mechanisms or styles. And there are roughly a total of 14 common mechanisms, which can be classified broadly into three categories, which I'm sure is no alien to you. There are some of us who are a problem solver where we are more rational and we focus on how to solve the problem, how to do things and we are more action based. And there are also some of us who are more emotion focused, where we are more in touch with our emotions and we need to um, uh, uh, so emotions can sometimes help us to cope better, but because it helps us more in touch with our inner self. Sometimes uh, those who are more emotionally focused are also able to gain more support and help from the social network. And there are, of course, the third categories, which are the strategies, styles that are maladaptive or that are not so helpful for the patient or caregiver. Those include examples would be those who are focusing on denial, or those who are using distraction strategies, or who do a lot of self-blaming, or they just disengage in their behavior of the problems. So we actually did a simple study in our own setting in our palliative care ward last year on 108 caregivers in the ward. And these are the 5 commonest coping strategies from the survey. So a lot of them utilize religion, acceptance, positive reframing, and also uh, um, active coping and instrumental support as their coping mechanism. And as you can see, they fall into 2 main categories. So there looks like there are a nice combination of both emotion focus and also problem focus strategies. The first 3 are from the emotion focus, and the second the 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 last 1 and 2 are actually in the problem focus strategies. And in palliative care, I'd just like to point out sometimes um, many people think the problem solvers are the more superior way of coping with problems, but this is not true in palliative care. Because in palliative care, we are dealing with illnesses or diseases that are no longer curable, and sometimes certain problems are not all problems can be solved, and therefore sometimes those who are focusing too much on problem solving are actually the one who is going to be constantly in bargaining phase and denial phase, and that actually um, hinder the patient and also caregivers to move into an acceptance phase of the disease and coming to coming in to reconciliation of themselves and also of the disease. So a combination of both emotion focus and problem focus strategies are actually more healthy and balanced in palliative care field. So for caregivers, we actually also try to identify caregivers who are on the verge of burnout And we do this by using the Zarit score. So for caregivers who look a bit tired or stressed or distressed, we invite them, or we actually facilitate them to complete a questionnaire called Zarit score, where certain scores will alert us that this caregiver may not be coping well and may need extra supports or time out from their caregiving role. And this is the same study we did in our ward. And you can see the mean or the average caregiver burden score is actually on the mild to moderate level. So about 40% of our caregivers says they have no burden. They don't feel burdened. And another 60% of our caregiver reported that they are either mild, moderate, or severely burdened. And some of the factors that we identify from our statistical analysis are categorized into three groups, which is number one is the blue factor, which is relationship. And that means those who are first next of kin, or those who are the spouses, parents, and children of the patient, tend to have a higher degree of caregiver burden compared to hired caregiver who are paid. And the second categories are personality. So we found out that caregivers who are more on the neurotic side or more anxious, they also tend to experience more sense of burden. And the third category is the coping strategies. And we are not surprised to find that caregivers who uses a lot of denial or venting techniques tend to be more burdened. So the conclusion from this study is that we are able to identify caregivers who are going to struggle quite early on if number one, if they are the first next of kin who are directly related to the patients, who are basically, we call them informal caregiver. Yeah, formal caregivers are the ones we pay, and the informal ones are actually family members who also have to juggle with other responsibilities like work and childcare. And the second group, and the other factors would be anxious personality and also certain maladaptive coping strategies. And this is the profile, the caregiver profile, that will alert us that the caregiver probably will be is struggling and we probably need extra help for the household. So what can we do bedside? So for those for patients who appear to have poor social support, the first thing we want to ask is why. So a family meeting will be able to help us to gauge whether this is a poor understanding, that the family members are not aware of patient's conditions, and therefore also not aware of the amount of caregiving burden that is required for the patients, and therefore the doctors will need to fill in the informations. And sometimes the poor social support is because of the very complex dynamic in the family, among the family members, and this probably require a bit more of coordinations and also communications to help them to help everyone understand and come into consensus on who is going to play the main caregiving duties, or if financial means are possible, perhaps a hired caregiver may help to solve the problem. And if the caregiver is very anxious, sometimes we bring in volunteers from our local hospices to support them. And if the problem is practical, such as financial equipment, then we'll also get our social worker on board. And for those caregivers that we found to have relatively unhelpful coping mechanisms, sometimes we will sometimes we will try to empower them with more helpful coping strategies. If we think they are too focused on the problem solving, sometimes we'll encourage them to express, to be more in touch with how they are feeling and how is the whole process, the experience, affecting them emotionally and also cognitively. And of course, if we feel they look like they're really struggling, we also screen them for anxiety and depression and make the necessary referrals to psychologists or psychiatrists if necessary. Next is psychological assessment. So for our patients, now coming back to patients, for patients who are facing a life-limiting illnesses, or patients with prognosis of, we're talking about sometimes weeks to short months, it is very common for them to experience grief. And so we need to recognize what is the normal reactions. We need to be able to differentiate what is a normal reaction to this experience in dealing with the illness versus what is pathological or how should we say, what is abnormal, which will require professional psychiatric inputs. So what are the normal reactions? These include anticipatory grief. Anticipatory grief means, as it says, the patient anticipate that he's going to lose his health, he's going to lose his social roles, and maybe lose his life. So and so that anticipations actually affects him cognitively and also emotionally, and he or she may actually experience a very intense sadness, and this is considered normal and acceptable for palliative patients. And some of the patients may also experience demoralizations. That means because of incurable disease, they feel helpless, and as a result, they may feel that their life is no longer meaningful because they've lost their mobility, their ability to move around, and their social functions as a husband or wife, and therefore it leads to hopelessness in life. Um, and they may have very poor motivations in their daily life. And these are still considered within normal reactions to someone who is having a life-limiting illness. But sometimes, if the emotional reaction or the cognitive reactions is so overwhelming that it starts to impair the person's social functioning, meaning he or she is not interested in talking, in eating, or socializing with family members or their loved one, or they are showing abnormal behavior or emotional state, then we have to ask if professional psychiatrists or psychologists needs to be brought into the picture. So examples will be adjustment disorder, depression, and also anxiety. So how do we actually differentiate between grief and depression? Honestly, it can be sometimes a bit tricky and difficult. And there are a few things that will help us differentiate between the two. So if it's a grief, then usually there is a temporal variation throughout the day. The mood sometimes can be good, but sometimes it's bad. So it's a yo-yoing rather than a persistently flat mood. And often, if it's a grieving reactions, if their favorite person turn up, their favorite family member turn up to visit them, usually they are very responsive to social support, meaning they will cheer up and they will be more talkative and they'll be happier. And often compared to depression, someone who is grieving, they often have preserved self-esteem or self-confidence and also preserved hope. So the hope may not be hope to live for 10 years, but there's a hope in maybe perhaps anticipations or in anticipation of the next social event or next significant event in the family, like a birthday party or a gathering. And for someone who's grieving, uh, compared to depression, there are still some preserved sense of pleasure, meaning they may still be able to enjoy their favorite food or certain sensory pleasures, or maybe like perhaps like musics and things like that. Whereas in depression, you tend to lose both consummatory pleasure as well as pleasure joy from anticipating the future. So this is the stages of grief. Many of you are probably familiar with. This is from the Elizabeth Kubler-Ross model. So she says people who are experiencing grief or with life-limiting illnesses, they often go through different stages of grief. So when they first know the diagnosis, perhaps there is a state of denial. They could be then followed by a state of anger, and then depression, and bargaining, followed by eventually acceptance. But in real life, it's often not so straightforward, and it's usually a very complex and dynamic processes. And sometimes patients also oscillating between different states of grief. And we need to be mindful of that. And this is what I mentioned. So a lot of time, patients, we should not be surprised that one day patient said, yeah, I know I only have a few weeks left and I'm very okay with that. I'm preparing myself um, to meet God. And the next day the patient say, no, I can I try a new medications? I think I'm not ready yet. I really want to live until my granddaughter is born, for example. And this is very normal. And this is what we call the dual process model of bereavement, where the patient will bounce between the state of hoping for the future, or and still bargaining um, uh, for things that they want. So in order to differentiate between grief and also depression, sometimes we also do a screening test. This is a formal screening questionnaires that we use called the Hospital Anxiety and Depression scale. So using this, we are able to kind of screen the patients who may potentially have anxiety disorder or depression. And if they score quite high, then we'll engage our psychiatrists for formal assessment and also consideration of pharmacological measures. And if we talk about psychological assessment, we often want to know how resilient is our patients. And by that, we mean the patient's ability to maintain or restore a relatively stable state of psychological and physical functioning state when they are confronted with stressful life events. And we actually also conducted a study on our patients in the ward last year. About actually, we were a bit surprised that almost more than a third of patients were screened to have high score in anxiety, about 33%, and almost half of our patients score high for depression screening. Then we continue to look at the coping strategies that they use. And as you can see, a lot of them utilize religion, emotional support, uh, instrumental support, acceptance, and positive reframing as their coping strategies. And if you refer back to the brief cope categorization again, you can see most of them are utilizing the emotional focus strategies, and only a small percentage are using active coping. And then we continue to look at what are the factors that leads to higher resilience in our patients. So on your left side are the factors that are associated with low resilience, and on your right side are the the coping mechanisms that lead to high resilience. And not surprisingly, those who tend to self-blame, who tend to be in a more denial state or disengaged behaviorally, tend to have lower resilience. And those who are using active coping, who are more proactive, who are more positive in their in their cognitive, tends to show higher resilience. And not surprisingly, those who score high on anxiety and depressions are the patients who are also having lower resilience. So what can we do for our patients? Um, for those who are who are grieving and we don't think they are in anxious or in a depressed states, we often offer supportive counseling. And what does that mean? That basically a bedside um uh, basic support, and we do that by using a lot of active listening, empathetic statements, and we do a lot of acknowledgement of their emotions. We validate their emotions and sometimes use a bit of normalization technique, and really this is to help them feel that they are heard and it's okay to feel certain emotions, and um to validate their own coping, their current coping. Other strategies that we also use will be further elaborated later in the spiritual sections. And this includes ways that will help them to see meaning or restore hope, but in a different way in their life, and also to restore their sense of dignity. Now, going into spirituality. So, what exactly is spirituality, and how is there even a definition for it? So there is. So this is the European Association of Palliative Care definition, which is very similar to the international consensus. In the inter the definition based on international consensus that came out, I think, a year later. So it says that spirituality is the dynamic dimensions of human life that's related to the way a person experience or express meaning, transcendence, and also relationship to the moment, to self, to others, to nature, or to the higher beings. And it actually mentions that these can be expressed or can be can be experienced or expressed not just through religion. So religion is just one formal, structured way of expressing spirituality, but there are also people without a formal belief systems who are equally spiritual. And they are the people perhaps who ask questions about meaning in life, who ask about that who actually have very strong values in life that defines them and keep them going in their life. And by spiritual pain or spiritual distress, the other word for it is psychoexistential suffering, and this is believed to be caused by the extinction of being or meaning of self, through the loss of relationship with others, loss of control, and also loss of sense of hope for the future. And where are the source of spiritual distress? So this is a nice diagram that actually gives us a broad framework on how to work on spiritual distress. So it could come from loss of connection with the self, with the people around us, with nature, and also with higher being. There's also loss of peace or loss of inner peace, and this could be because of sense of guilt, shame, or anger, uh, inability to reconcile with the past or people. And then there's a loss of meaning or purpose in life, perhaps because of um, loss of job or loss of their societal role. And then, of course, there's inability to find connection or to transcend to their higher state or their their better state of self. And sometimes this could be experienced as perhaps confusion or conflict with God and a sense of abandonment by God. And this is again a nice table that summarizes what are the common spiritual concerns that we often hear from our patients. And again, it can be broadly categorized into three big groups. The first group is related to existential. So many of our patients ask questions like, why me? Some ask, why me? What have I done wrong? Did I sin? And why do I deserve this? And another group of patients will ask, um, can I have a swift death? I don't see the point of continuing living. Can you just give me something so that I can go now, so that I don't become a burden to my family? And then the second category, the one in pinks, the spiritual concern related to their connection with the higher being or God. Uh, so it could be them feeling being abandoned despite their prayers. It could be them trying to bargain with God, or having a conflicted belief systems, or of what they believe God will do for them versus what's being told or what's being promised in the holy text. And the third group are the ones in green, and these are the spiritual concerns more related to their interactions or their connection with people around them. So it's really about, for example, isolations where they don't feel a sense of connection with people, or guilt. They they might have not been their best version of themselves to other people, or there has been um, old grudges and they are still not able to reconcile. There's also another group, I think a very significant theme that was not included, which is the loss of dignity, where having a terminal illness sometimes deprive us of our sense of wholeness and also sense of self-respect. For example, sometimes the disease will cause us to lose functions of our bladder and bowel. And can we imagine a 70 years old professor now having to rely on the daughter to change his diaper, and he has to have a urine tube being inserted. So that's, for some people, that's just not acceptable. And also sometimes the disease um may cause the patient to lose certain body image. For example, breast cancer. So the patient may not feel whole as a woman if she lost her breast from the surgery, or if she has or for someone with ear, nose, and throat cancer, which is very disfiguring. Imagine having to walk around even in the house, or not in the street, even in the house, with a huge mass protruding from your cheek, or with a huge hole, ulcerating in the mouth, with the tongue dangling, with a missing chin. I think, and usually these tumors tend to be very foul smelling as well. So um, these are the issues, potential issues that may impact the dignity or sense of wholeness of the patients, because there will be judgment and also stigma from the people around them as well, because of the way they look, or the way they smell, or the way they carry themselves. So the purpose of doing any bedside interventions or therapy at all for psychospiritual issues um, would be, I think, there are three main key points. Number one is actually to first remove or reduce the emotional components of anxiety and demoralizations and fear, which is related to their sense of helplessness, and the sense of helplessness from the disease itself, and also from the uncertainty in the future. the second tip will then be to help them to redefine what's important in their life and prioritize what are the things to do with a limited time. And the third one, if they're ready or if they agree, then perhaps is to look at some of the coping skills they have that's helpful or not helpful to them. And if they are ready, perhaps we can introduce some helpful skills to make the process or the journey more tolerable for them. So for the first part, the emotions, so we actually do a lot of like I mentioned before, active listening, empathetic statement, and also acknowledging, validating all the negative emotions that they are feeling, instead of suppressing this feeling, because some of them feel shameful for experiencing certain negative emotions. Um, a lot of our role is actually to provide a safe space for them to express those negative emotions, to help them to accept that negative, to recognize that having negative emotion is not a shameful thing, and it's actually important to provide a safe channel to express them. If they're not able to do so verbally, sometimes maybe through other arts or paintings or other ways that are safe, like doodling. Some patients find it helpful to doodle or to paint. Um, Next is a cognitive. So how do we then help them to realign their priorities? And often we find this has to come from them internally, when they're ready. So what we can do is actually just to help to facilitate them with their reflection. And in palliative care, we do many advanced care planning discussion. So this is about thinking about future and how thinking about what is meaningful and important for them right now at this phase of their illness, and what would they like to be done, or what types of care they would like to receive in anticipations of future deteriorations. And sometimes, if patients have catastrophic thoughts, we also do reality testings and helping them to clear some of the fears and worries that are uh, unnecessary or unjustified. So, in terms of coping skills, we have seen, I think you've seen that already. There are many strategies that people use, and sometimes it's important to find a balance between problem solving and also emotion focused strategies. We also sometimes do meaning centered therapy, where we help patients to do life review and also legacy work, to help patients to see meaning behind the suffering, to see meaning in their life, especially for those who are requesting for hastened death because they see it being pointless to continue living. And we also do dignity therapy. So we find there are strategies and there are ways to help people to restore their sense of dignity and wholeness. And there's also something called ACT, or acceptance commitment therapy, where we actually teach patients to be more grounded, to be more present in the moment through mindfulness, and also help them to remind them of what what um, what matters most to them, i.e., their values that they hold close to their heart, and to remind them how they can still continue to live um, in with the illness by upholding their values. So these are the examples of life review that we do in the ward by our occupational therapist. So she actually do a wheel of a life, including childhood, adolescence, and early adult life until current stage, where patients are encouraged to talk about what are the significant events in their life, and also how do they feel, how would they define that phase of their life, and you can see emoticons, stickers are placed in different phases of their life. And through this live review, the whole purpose is to help patients to focus on things that they have done well to restore their sense of pride in their own achievements. And of course, in sometimes to also elicit things that will be able to help them um, um, to ignite that sense of gratitude in them about life. And this is just a slide to remind us some of the good strategies or helpful strategies that 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 will help to improve or boost the resilience in patients. And this is my last slides. So in order to, when we are supporting patients spiritually, it is important, we often remind ourselves that everyone have a unique belief systems and they should be honored and respected. And this may not be in the form of religions, and they could be in other ways, existentials and also value-based channels. And it's important that we always maintain our boundaries when we support them. And in of course in palliative care we don't talk about religion, especially because in Malaysia we have a multi-faith and multicultural societies. We try to be faith neutral or faith sensitive, and stick to the more secular ways of supporting patients spiritually by helping them to see meaning, by fostering hope in a different way, and by encouraging them to reconcile with their themselves, and also to find peace within them. And this is my last slide, and thank you very much.
Thank you, Dr. Yun.
Thanks. Yes.
Yeah, thank you. That was very, very informative, very clear. I'm a lay person, I'm not a medical person, but I could understand the depth to which you took us and the sensitivity with which you taught us how to handle this. Now, let me just look at the questions. This is a time for questions. Anyone has questions, please raise your hand or write it in the chat. The first question that has come is, what is self-distraction? Can you explain self-distraction?
So distraction is one of the technique that sometimes labeled as not so helpful. That means instead of focusing on the illness or your own experience, you try to distract yourself. For example, perhaps watching TVs or focusing on other things. For
Mm,
example, one of our patients say she really liked people visiting her, people from her church visiting her, and initially we were delighted to hear that. So we asked her, "Oh, what about their visits um that make you so happy?" She said because then they started telling her about their own stories. So she
mm,
enjoyed the storytelling process and get distracted and she will forget about her own problems by listening
mm,
to gossips and different their own problems. So
mm,
perhaps I don't know, so whether or not this is a helpful way of dealing with her internal turmoil to help her
mm,
transcend and progress, uh,
mm,
maybe not for
mm,
everyone. Maybe temporary, yes, but
mm.
in order to progress, I think internally, uh, this may not be the best strategy.
Yeah. So what you're saying is it's a journey you have to walk through, not
Yeah,
distract yourself away from. Yeah.
yeah.
Thank you. Thank you. Any more questions?
I would
Yes.
like to ask Dr. Srinivasamurthy. He's a
Yes.
psychiatrist here in India in a very prestigious institution. So,
Okay.
Dr. June, you clearly said that you need a group of people, right? Because
Mm,
we are nuclear families and terminal cases, nuclear family desert you. I mean, they've no time. They can't be sitting with you all the time. And people, from church and other groups will just visit and go away. But there is no one to really sit and listen to you. Dr. Murthy, in India, do we have such a support that Dr. June was talking about of, psychologists, occupational therapists, and others jumping in when there's no one to be with a patient? Do we have that
Thank
in
you.
India too?
Thank you very much, Hansa. It has been a very comprehensive, very good presentation. Thanks to the speaker. Thank you very much. One of the things that is common things you hear from everyone with end of life or cancer is it is a life-changing experience. Life is no more the same after the diagnosis, even when you have, lack of relapse or disease control. And it is unique for everyone. Everyone experiences depending on their social situation, family situation, economic situation, stage of life, and other things. Many of us medical people are still worried about addressing spirituality. The way what
Yeah.
has helped in my work is as follows. Instead of asking, what is your problem? What can I do? If you start with the two other questions, how has your life changed? Immediately they'll tell a whole lot of things. Then you ask them the next question, what has helped you? 10 out of 10 tell you that it is the family and their spirituality. Then you can ask, what is the need and how can I fulfill it? And the way to, I am much more aggressive or much more active than what our speaker talked about, that I use the stories from either Bible, Quran, or Gita to help them understand the pain, suffering, uncertainties, fear of recurrence, fear of death, and all the other things. Because otherwise, just saying that forget about it doesn't help. But if you could give a situation, I'll give an example to you. This is a patient who had severe guilt about not having donated her kidney to her brother who died. Anything I did didn't work out. Then I used the story of Buddha and Kisa Gautami, how she came with a dead son. And when she went around the house, found that every family has a death. She accepted death much more than others. This really happened in my professional life. I can tell you any more number of stories. So I think we need to think of our spiritual resource, whether it's the Bible or the Quran or the Gita or Mahabharata, Ramayana, whatever it is, as a very important resource. Sometimes it's more powerful than the analgesics and antidepressants, anti-anxiety drugs, and other
Yeah.
things. The most important thing is each one of us have to get over and recognize this resource is available in the community to make meaning and come to terms with it. Thank you very much.
Thank you, Dr. Shini.
Thank you, Dr. Srinivasa. Very, very true. I do find when we ask them questions, what are the things, what are their source of strength? Often, indeed, it is either family or God or their religion. So yes, and we must tap into these two resources if we want to support those who are struggling.
Mhm.
And
Uh,
yes, I hope I can one day be more be as imaginative as you are. We rarely use narrative. I think not so sure why is it in Malaysia because we are very sensitive with religion. We're very
Yeah.
careful. We don't want to upset the people who may perceive us as, trying to if I am seeing a Muslim patients, I'll be very careful to quote the Al Quran because I'm no expert. And Christians, I haven't read Bible twice. I read perhaps half of the
Mm.
Bible. So again, my stories are not so rich. Perhaps, yeah, thank you for the suggestion. I should read more and get more familiar with the stories. Yeah,
Yeah.
thank you.
I've taken
yeah.
the
I
liberty to post one of my writings, which illustrates with examples how I have used
Mm,
cancer and spirituality. Thank you.
mm,
Mm.
yeah,
I had a similar
Yeah.
experience, Dr. June. I think
yeah,
what you're saying is we need to listen to the patient.
ah,
Often we don't listen to the patient where they are, whether they are bargaining or they are depression, anxiety,
mhm,
or they've accepted. See, it is such a mixed solution. I
mm,
remember one doctor, a radiologist who
mm,
had cancer and he was
mm,
dying. And I met him. When I met him, he was so confused. And he said, Hansa, I want to sit with you alone and talk. And he said, everyone is giving me all kinds of inputs. I need to know just one question. Can you tell me where am I going? What is my future? That was clear, beautiful. I sat with him, took the Bible, showed him how heaven is a beautiful place. He was willing to listen, not that I was forcing it on him. The heaven is a beautiful place, what he has for you, and with examples, with all the quotations and with all the Bible verses, historical, geographical proof in a very short way. He was so peaceful and he said, at last I have found my peace. A week later, he passed away. So, what I was trying to say is, uh, it is wonderful what Dr. Srini is saying. Dr. Srini is a psychiatrist who has concern for people, but not
Yes.
all psychiatrists have the time. Not all caregivers have the time. Even family members don't have the time. So, we in the church, we have to form a group of people who can listen to the patient, find out where they are, give them what they need, get also occupational therapists, psychologists, others to form in. It is so important that we form such a team and help
Thank you.
people who are suffering in terminal cancer. I'll stop with that.
Thank you, Dr. Hamsa. Yeah, in our church, we are forming what we call a safe space for listening. We're just in the process with a network of, experts supporting it. So it's a good thing. There's one more comment by somebody who's a patient. It is Asha Gerard. She says that as a patient, I found this very helpful. She doesn't have a very strong support system. I know her. Yeah.
Yes, and my
We have
belief in God
Yes.
is really helping me to carry forward. And
Yeah.
people who are willing to listen to me, mainly,
Yeah. Yeah.
more than the depressants, antidepressants, and medication.
Yes.
Though
Yes.
I feel people listening really help me.
Thank you, Asha.
One other, if I
we
can come in
have
for
a
briefly, there is enough new literature coming showing spirituality can bring about biological changes.
Whatever
Yes.
I've
You know,
been
this
going
is a
through.
very new area. Probably one of the sessions we can address on that, whether it's the purpose of life, whether it's acceptance, gratitude. Now, more and more is being shown through the fMRI and other things that they bring about biological changes, not just psychological changes. Thank you.
Thank you, Dr. Shri. I'm reading a book which
Anita.
talks about the plasticity of the brain and those who have spiritual belief, how their neural networks are positively rewired. It's an interesting discovery that they're making. Yes. Any other questions or comments or observations? Okay, then. That was such a relevant talk, Dr. Jun, and we look forward to many more. Dr. Hansa, would you like to give a vote of thanks?
Oh, well, I do want to thank everyone here who came over to listen and to encourage, and Dr. June. And Dr. June, we want to say that this was such a powerful talk that you gave us, and India has to learn too that we too get a support group like you, and we need to help you also to continue to do your work in Malaysia. And this was so beautiful that we learned from each other that treating the final quotation that you gave, a doctor treats the patient, but but the real caregiver treats the mind of the doctor treats the disease, but the real caregiver treats the patient wholesome. We need to give that wholesome care. That was a fantastic quotation. So we are very grateful to you for bringing that point over to us and the discussions. We want to thank you, Anita, to have hosted this program, Mega, to have discovered you and brought you here to us. And we want to thank Dr. Srini always for his, a psychiatrist, always there ready with his input and helping us. So I want to thank all of you here. It's such a wonderful program, especially Dr. June, making the time, in
Yes.
spite of your expertise and your you took the time to teach us how important the psychosomatic nature, the psychological aspect for the patient is so important, and you brought that out so clearly. We're so grateful to you.